Okay, we have a bit of a jam-packed agenda today, so I'll make a start with some of the housekeeping, but welcome everyone and thank you for joining what is our second debrief webinar post EASL. We've got a really nice range of talks and it's a joint effort between the nurses, the HPs and the pharmacy subcommittees of BASL. So we don't have the raise hand function. So if you've got any questions after the talks, if you just want to write them in the Q&A facility or write as you go along, and then I'll take those questions at the end of each talk. We've got a little break in the middle between 5 to 5:10, and I think we've got a good range of different topics. So please listen out and ask any questions you like. We're a friendly group. And lastly, I just want to thank BASL for organising this with us, and Dr. Falk, Ipsen, Gilead and Norgine, who have supported this webinar for us. And it's really fortunate that we get to organise these things up free for BASL members and I think non-members this time. So I'm going to crack on a little bit earlier with Dianne Backhouse. So Dianne, she's our lovely hepatology clinical nurse specialist from Hull University Teaching Hospitals, and she's also the chair-elect for BLNA. And Dianne's going to be providing a summary of ACLF and the interprofessional posters at EASL this year.
Thank you,
Dianne.
Thank you. Hi, everybody. I'm just going to share my screen so that we can have a look at some slides. So I wanted to do a little bit of a focus on the nursing highlights from EASL. One of the sessions that I attended was from the Interprofessional Forum was the MDT approach to ACLF, and I also attended the poster tour, which was the real life session. Unfortunately, I couldn't get to all of the nursing sessions as I was doing some of the FibroScan skills workshop tutoring, but these two things I found really useful during the EASL conference. So the first one I wanted to talk about was this. It was entitled Always Be on Alert. It was a multi-professional treatment of acute on chronic liver failure, and this was provided by a team from Rotterdam that included a nurse, a dietitian and a medic, and included a bit of a panel discussion at the end, and they were presenting on ward-based care of ACLF. And I think this is a really relevant topic to us all, and also, definitely to the ward staff that don't always get the opportunity to come to these face-to-face conferences. So that's why I wanted to bring it to the webinar. And it's a little bit different to what we often see at these conferences, with it being more sort of ward-based. And as we all know, these patients, they're on our wards that might not be a hepatology dedicated ward. It might be a gastro ward, and they're often the sickest patients on the ward. And it's us as healthcare professionals, nursing, AHPs, pharmacists that are seeing these patients on a very regular basis, providing hands-on care, and often seeing that these patients are their conditions changing, or they may well be deteriorating. So this session gave us a good overview of what to look out for. So the session was based on a case study, and the case study was this chap who was a 55-year-old male with Hep C and alcohol-related cirrhosis, also a bit of Met-ALD as well, really, because he was type 2 diabetic and his BMI was a little bit raised. He presented at the hospital with a sudden onset of jaundice and recurrent ascites. His Child-Pugh score was 12 and his MELD was 17. As we said, it was related to alcohol, particularly this admission, and he was drinking 400 mils of wine a day and some vodka, but it was unclear how much vodka. His nutritional state is mentioned there, and his last dry weight was 88 kilograms, but obviously he had 10 kilos of fluid basically on board on admission. They'd recorded a frailty assessment on him and he was classed as pre-frail. He lived alone and had 2 adult children, and he worked in a restaurant. And we can see by the pathology results in the table there, his albumin's on the low side there, and he was very jaundiced. His bilirubin was over 200, as we can see there. And creatinine, very upper limit there of 131. So I'm going to go through a bit more about ACLF, and then we're going to come back to our case study. So what I liked about this session as well was particularly this table, the overview of ACLF, because I think sometimes we all get a little bit mixed up of what do we mean by this, how does it fit in with acute liver failure, how does it fit in with acute decompensation, and how do we know the differences? So I found, I think people will find this very useful. So in terms of acute liver failure, there is no pre-existing liver disease there. Okay, and usually an acute liver failure happens. It's a sudden sort of onset, sort of within 12 weeks of the start of symptoms. Whereas with decompensation and acute decompensation, they will have pre-existing liver disease, but it could be their first presentation of decompensated cirrhosis, for example, or it could be a long-standing decompensated cirrhosis that's then sort of worsened, kind of thing. So it could be the first presentation. The liver disease might have been known or unknown at that point. Whereas acute on chronic liver failure, yes, obviously there's pre-existing liver disease there, and it could be the first presentation again, but we're talking about acute decompensation and also some organ failure on top of the liver problems as well. So we'll go into that in a little bit more detail. There was a good discussion around the definitions of ACLF, and there are varying definitions across the world. Obviously, us being in Europe, we use the EASL Cliff definition. I'm not sure how well that projects on the slide there, but we talk about the grading of ACLF with ACLF 1 with sort of 1 extrahepatic organ failing. ACLF 2 would be 2 additional organs failing, and ACLF 3 would be 3 or more organs failing. So a bit of background into ACLF. The worldwide prevalence is 35% of hospitalised patients with decompensated cirrhosis, and we all know that we see these patients a lot on our wards. So just to be aware that a high proportion of these people could then progress on to ACLF from that decompensated cirrhosis. There's a higher rate as well of 90-day mortality, as stated there, at 58%. And there's lots of different reasons why that may trigger the mortality. So it could be the underlying liver disease, it could be trigger factors, it could be the type of organ failure, for example. So some of the precipitating factors that might make the decompensation progress into ACLF would be quite often infection. Could be a GI hemorrhage, such as varicose bleeding, for instance, or it could be procedures such as a TIPS procedure, large volume paracentesis, or even some endoscopic procedures such as ERCP. There could be intrahepatic issues as well, such as viral hepatitis, ongoing alcohol use, which is the issue with this chap that is in our case study. Could be a DILI or an autoimmune disease, or there could be some non-identifiable problems, or more than one thing going on, which I think is what we often see with our patients. It's not as clear-cut as having one thing going on. So a little update on our chap. He has hepatorenal syndrome, he has HE, and he's got some abdominal pain. His MELD score there is now recorded at 37. He's on some lactulose, and he's also on some terlipressin. He's been seen by the dietitian, and he's at risk of malnutrition using their point system that they use in Rotterdam there. And his liver frailty index has changed. He's classed as frail now, whereas he was pre-frail previously. The ward did an animal naming test for him, and he was only able to name 5 animals in 60 seconds. And for those of you that are not aware of this testing method, we should be aiming for at least 15 animals in a minute. Otherwise, anything less than that would indicate some cognitive issues there and an indicator of HE. His family had visited and expressed the concerns about how he would manage, because he's clearly not himself at the present time, and obviously how he would manage with things like addiction therapies, etc. In terms of his bloods there, his albumin has come up a little, but so has his bilirubin. So we've now got a bilirubin of over 500 for this chap. And his creatinines worsened as well. So we've gone from 131 to 326. So clearly things are changing with this chap. So we've got his kidneys certainly very much involved there now. So the focus of obviously of this talk was about the MDT approach on the ward. And as I've mentioned at the beginning, it's about the team, being there, providing hands-on care. They're the ones chatting to the patients, delivering their care, hands-on care, touching the patient, in terms of being able to feel if, they may have a temperature or something. It's us that can determine these early indicators of things deteriorating with our patients. As this chap was related, his trigger was related to alcohol, there was a focus on treatment for alcohol withdrawal and also the non-medicinal treatment in terms of supporting his alcohol abstinence and whatever support measures he needed there. I think one thing to bear in mind as well is, as it mentions there, is about reorientating the patient to their surroundings and avoiding moving patients as much as possible. And I know that in the current where things are on wards, people are often nursing corridors, for example, but people will be moved around because they're not in their base wards, for example, from the get-go kind of thing. So it's just being aware that will have an impact on these patients and their cognitive function as well. So just to revisit ACLF, this slide pictures the organ systems involved in ACLF, which is cerebral, the respiratory system, the circulatory system, obviously the liver, coagulation and the renal system. And the right side of the slide shows us additional organ systems whose function might be altered in ACLF. So that could be the heart with something such as cardiomyopathy, the immune system with some immune deficiency, adrenal insufficiency, the gut, for example, and also muscles in terms of sarcopenia and frailty. And again, at the bottom, I'm not sure how well it shows on this slide, it talks about the ACLF grading from 1 to 3. So I'm just going to go through these systems in a bit more detail, each of how we can be monitoring and looking out for things on the wards. So we'd be monitoring for HE. In this particular department, they did that every 2 hours. They would be also doing animal naming tests. They would be avoiding sedatives, which we all know. This patient was prescribed lactulose and rifaximin as a treatment for HE. But if they do develop grade 3 or grade 4, that would be, indication for intensive care unit and possible intubation. On the right hand side there, just a reminder of the grades of hepatic encephalopathy, grade 1 to 4, also covert and overt, for those of you who are not aware of that or need a reminder. So in terms of the respiratory system, if the patient has respiratory distress, all the things that we'd be looking out for: high respiratory rate, gasping for breath, shortness of breath, using accessory muscles, their colour may well change, they might be quite restless and experiencing discomfort, could be some wheezing, their oxygen saturations may well be low, or they may already on oxygen and therapy, and that might be the need for that could be increasing. And obviously, if the blood gases are deteriorating, we may well need to think about ICU for ventilation. In terms of the circulatory system, we would be observing them for a low capillary refill, or slow, should I say, a low blood pressure, tachycardia, cool peripheries, a weak and thready pulse, a sweaty appearance, and if the circulation deteriorates again, they may need transfer to ICU for vasopressor treatment. I'm sure we've all had experience of bleeding secondary to portal hypertension, so it's important to be aware of this. And one of the things that we'd be looking out for on the ward is signs of bleeding. So are they vomiting blood? Is there any melena there? Keeping a stool chart's very important. The team would be looking at the hemoglobin levels, we'd be looking at their observations in terms of the blood pressure and the heart rate and the respiratory rate. These patients, obviously would need intravenous access because they could become hemodynamically unstable very quickly. And again, somebody with bleeding varices in this situation most likely would need to be transferred to ICU for further management and treatment. There was a mention of tips being considered in these patients with ACLF for portal hypertensive bleeding. And just to reiterate, really, often we wouldn't consider tips in someone with hepatic encephalopathy, but that's more of a case of someone who's known to having cephalopathy previously. But if this is a new issue that is literally related to the ACLF, then that wouldn't be a contraindication for these patients. So we would still consider a TIPS if there was variceal bleeding and the HE was secondary to the ACLF and not pre-existing. Renal function, I mean, we all have this in our minds whenever we see patients, whether I think that's an inpatient, an outpatient, or whatever. We're always very keen on knowing what somebody's renal function is like. But particularly in the ward area, we're going to be checking the urine output, keeping a very strict fluid balance, reporting, when the urine output changes. We're going to also be recording weights. These patients might be on diuretics, so that might need to be suspended if the renal function is deteriorating. We're going to be monitoring the bloods very regularly. They may well require some IV albumin to help perfuse the kidneys, perhaps. We're going to be monitoring for ascites, and if they're needing an acidic drain for relieving some of that pressure, then as well they're most likely to be receiving albumin for that. We're going to be looking and checking them for edema, because it might not just be ascites, it could be edema anywhere, basically. And patients who have HRS would be receiving treatment in the form of telepressin and albumin. If things worsen significantly, they may well get transferred to ICU for hemodialysis. And just a quick note on hepatorenal syndrome, should only be administered by nurses who are trained in this. And in this unit, they use a continuous infusion, but I'm not 100% sure if that gets done everywhere in the UK, but I think that's something that potentially moving towards to reduce the risk of side effects. We don't give that telepressin as well on a line with anything else. It has to be a dedicated line, and we need to be checking regularly for signs of any sort of ischemia, whether that be the hands or the feet, or even bowel ischemia, abdominal pains. I remember a patient with a significant reaction to telepressin with severe abdominal pain that had to be stopped due to that. Just moving on to infection, it's one of the biggest sort of drivers of decompensation and subsequent ACLF. So we're going to be monitoring for infection. Have they got a temperature? Have they got a fever? What's the bloods like? Have they got a raised CRP? But also to be aware that that doesn't always rise in this patient group. Have they been checked out for spontaneous bacterial peritonitis? They don't always have abdominal pain for this. With this, should I say, SBP can often be asymptomatic. Is there a risk of cholangitis there? Looking for any signs of that. Is there a respiratory tract infection? Is there a urinary tract infection? And we need to administer antibiotics appropriately. But if this patient is experiencing sepsis, then again, another indication for ICU transfer in this patient group. There was as I said at the beginning, there was a dietitian on the panel who provided some good advice, a lot of it which we'll all be aware of, but just as a reminder to that nutrition is extremely important within liver disease and liver cirrhosis, decompensation, and particularly ACLF as well. And all patients with decompensated liver disease and or ACLF would need dietitian referral and input. And I think we all know that a lot of our trusts don't have a nutritional assessment tool that particularly always identifies liver patients like this as high risk, but just to remind our teams that these patients do automatically qualify for a referral to dietitian. We know that these patients have a high energy requirement and often won't be meeting their energy requirements orally, even with oral nutritional supplements. So we have an early threshold for NG feeding, and even they talked about parenteral feeding as well in this group that they sometimes do in Rotterdam. So the usual rules apply in terms of eating little and often, small, very regular meals, having the adequate amount of protein, no added salt, a bedtime snack. We all know these things, and it's, you know, that same information, reiterating it to our ward staff if they're going round with the tea trolley for the evening cups of bedtime drinks. You know, can we offer them a slice of toast or some cereal at the same time? If the patient wakes up during the night, could they have their nutritional supplement at that point? You know, it's about being flexible and making sure that these patients are getting the nutrition that they require at the required time. And also thinking about fluids. You know, can we offer some nutritional fluid with some nutritional substance as opposed to just water? And as I say, for example, a hot milky drink at bedtime would be a lot better for that patient group. The panel discussed liver transplantation in ACLF, and as stated there, grade 3 and grade 4, they would be have a rapid workup for liver transplantation because it would be more of an immediate need, whereas someone with grade 2 or grade 1 or grade 2 ACLF, they would start the usual sort of workup, thinking if things don't improve, do we need to be thinking about transplant? And the slide there demonstrates the sort of the more rapid workup. And as well, we need to always remember the importance of parallel planning with palliative care in this patient group as well, in terms of things might not go as predicted in a positive way. So just a reminder as when to refer to specialist centres. So an early transfer or contact is always recommended for discussion. Patients with chronic liver disease that are already on the transplant waiting list and who are admitted with ACLF should be referred to the specialist centre so they're aware of this. If things are unclear as well, is it an acute liver failure or is it is it ACLF? Okay, if the ACLF is greater than grade 2, so multiple organs involved, then do we need to think about expediting a transplant assessment? And obviously, if there's a worsening clinical trajectory or multi-organ failure in that first week of admission, so things are progressing very, very rapidly. And also, we may well refer when we need specialist management, either for something such as TIPS or a transjugular biopsy or complex interventional radiology. So when to refer to an ICU, if they're needing organ support, as we know, they might need vasopressors, they might need ventilation or renal replacement therapy. If they've had a massive bleed, such as a varicose bleed, and they're very hemodynamically unstable, if they have grade 3 or 4 encephalopathy, or if there is evidence of septic shock. Okay, it mentions some contraindications there to ICU, which may well be considered, such as a poor short-term prognosis, elderly patients that are unsuitable for liver transplantation, but obviously would need to take into account how they're progressing and any other comorbidities, an extreme frailty or sarcopenia, or if there was a advanced neoplasm. So to give you a little update on our chap, so his kidney function stabilised out and he was treated on the ward for 3 days, but then he did experience a sudden GI bleed, a varicose bleed, and was treated in intensive care for 4 days. He was then stabilised, but then transferred back to the ward, had a long recovery period on the ward, and was discharged into a rehabilitation clinic after nearly 3 months of a recovery on the ward. And then he went on to have outpatient addiction therapies. And then 6 months after his admission into hospital with the decompensation and the ACLF, he was then added to the transplant waiting list. So finally, there was a discussion, quite a long discussion with the panel about varying topics. It was a really good discussion following the presentation about including things like the definition of ACLF, involvement of other members of the MDT, including physiotherapy and how much should we be moving these patients, trying to get them more mobile and things, and a lot of discussion regarding nutrition, which is always, as I've said, a massive focus in this group. Okay, so that is a little whirlwind tour of ACLF and the talk that I attended there. I've got a couple of posters. I hope I'm okay for time. A couple of posters from. Sorry,
another minute, Dianne, but carry on.
Sorry.
That's okay.
Time flies, doesn't it, when you're having fun?
I know, tell me about it.
Right, I'll go quick. So I attended a poster tour, slightly different to how things used to be done. They've done it like this for a couple of years now. A number of posters are picked out by the EASL team to do a short 7 or 8 presentation on their abstract kind of thing. So one that I picked out was about a nurse-led clinic for decompensated cirrhosis by a team in Denmark. They wanted to establish this clinic, and they, which they did do. They had 55 patients included, and actually the interventions through this clinic allowed a reduced rate of further hospital inpatient attendances and further ad hoc sort of clinic attendances as well. So they really felt that developing a nurse-led clinic for decompensated liver cirrhosis was really useful. I must say, from a personal perspective, I totally agree with this, because I do that as well in terms of my discharge clinic, which I would say has similar impact in terms of trying to avoid further hospital admissions and seeing people very regularly to keep them out of hospital. Final one was actually something local to myself. Our own team in Hull presented the Community Liver Health Check project that our team are providing, which provides a fibre scan at risk people with at risk of liver disease in community settings, people with long-term alcohol excess, diabetes or obesity, and previous exposure to hepatitis B and C. The team have scanned nearly 3,000 people from April 23 to September 24, and we've found a number of cases that need to either be seen by the liver team for ongoing support and management. A number of patients were discharged. We actually found one case of HCC in somebody that was undiagnosed cirrhosis at the point of admission into this programme, which is absolutely amazing, and that was treated. Also found a case of renal cell carcinoma and other cases of Hep B and PBC. So the outcomes of this is that the nurse-led service offers a unique approach to the early identification of liver disease. There's tailored specialist-led liver education advice given during those engagement processes, and it offers a smooth referral into secondary care. Thank you. I apologise if I've gone over time.
All right, Dianne. So much. I mean, it's so nice to actually get a talk about something that's more relevant towards staff rather than in outpatients. I just had one question. We have obviously dedicated liver wards, but I don't think everyone else is quite as fortunate. And, there's lots of patients that will be spread across the hospital, medical wards, A&E, acute medicine. Is there any tools or training that you would recommend for general ward nurses so that they can recognise when a liver patient's deteriorating?
So I know in our own trust, our local trust, myself and the liver nurse team do provide education to nurses from all wards. So it's called our Liver Nurse Day, for things to look out for, and I think that would be something good to replicate throughout all trusts. I know a lot of trusts do that. But I think it's about, because it happens here as well. We don't have a dedicated liver ward. We have a gastro ward. The liver patients are cared for on there, but they're not always. They could be on a surgical ward. They could be on an elderly ward, for example. And I think this highlights, a lot of the sort of national agenda type issues that we need to be raising the profile of liver disease and getting it more understood by general nurses on general wards, that actually these patients are sometimes the sickest patients in the hospital. I think there's a lot of work to be done there, and I'm sure we'll all be very happy to be involved in trying to improve that.
Yeah. Oh, thank you so much.
Yeah.
We've got a short Q&A session at the end, actually, but there's one question from Karen. Have you expanded the area you cover in Hull with the the Community Liver Health Check service?
Yeah.
And do you have capacity with staffing or current staffing, I think?
So our nurse Beth is the nurse that presented this, and she is in charge of the Community Liver Health Check scheme, and she has visited other areas outside of Hull, so sort of up to Scarborough area. I know we're looking south of the River Humber, and done some bits and pieces in other areas. Obviously, it's difficult to negotiate how we can accommodate that, because it's such a wide area, but that is in the grander scheme of things, of how we can make this our usual practice, our day-to-day work kind of thing, because clearly it's had a massive impact and very positive results.
Yeah, great, thanks so much, Di. So I'm going to move on to the next speaker. We've got Hannah. Hannah Hesketh, who is a specialist hepatology pharmacist at St George's Hospital in London, and she's going to provide an overview around sort of all the updates with PBC, and also touch upon HBV and MASLD sort of new medications and guidelines as well. Thank you, Hannah.
Thanks, Vital, for the introduction. Today I'm going to be speaking about the pharmacy highlights from the EASL Congress in Amsterdam. I had initially planned just to speak about PBC, but I think it would have been quite rude not to mention the new hepatitis B guidelines, given it's a pharmacy update. So we'll briefly speak about those. I'll speak about one of the newer treatments for MASLD, and then I'll come on to PBC treatment, second-line therapies. So the EASL 2025 hepatitis B guidelines were probably one of the most exciting topics of the conference. Here is a very nice simplified summary flowchart of the new guidelines. The guideline itself is very extensive with 10 different chapters, but today we'll just focus on the treatment indications for starting and stopping. The definitions of the phases are all still the same, and they're included in the guideline. As we can see in this flowchart, anyone that has a positive hepatitis B surface antigen and who has got fibrosis or cirrhosis and a detectable viral load should be offered nucleotide treatment. If they have a low hepatitis B viral load and no fibrosis or cirrhosis, then they have a low risk of disease progression. So treatment's not indicated. So that's different to the Asian guidelines, who don't have a hepatitis B viral load cutoff. We also should be considering any other causes of transaminases being elevated, for example, MASLD. There's strong evidence to recommend for patients with a hepatitis B viral load of over 2,000 with elevated liver enzymes or fibrosis, or if they have any risk factors for liver cancer, then they should be started on antiviral treatment. They did include some recommendations on stopping nuke therapy as well. So we know that anyone who has got a negative surface antigen should be stopped with the nucleotide treatment, but there is new evidence to show that those who have got a positive surface antigen can also be considered for stopping nucleotide treatment. So this would need to be obviously discussed with the hepatology team. And we also would need to consider in these patients their level of hepatitis B surface antigen. So if there is a decision made to stop these patients, we obviously need to monitor these patients a lot more closely, because they are at risk of having a relapse or a flare. I mean, this brings in quite a lot of complications to our practice, because we will need to be monitoring these patients a lot more closely. I know at the moment there is a working group looking at these new guidelines. They're looking at the hepatoma surveillance frequency, but also what we do with these new guidelines and how we fit seeing these patients into practice. I think this is where pharmacists and nurses will come in a lot more as well, as we have a lot more clinic capacity, so we can see these patients more frequently. So this concludes the hepatitis B updates from EASL. There were obviously a lot more talks as well on new therapies for hepatitis B. Our aim is obviously looking for a cure, which we don't have at the moment, but there are some exciting trials currently in phase 2. So resmetirom is a treatment that has been approved in the US for MARSLD. It's not yet approved in the UK, but it's likely that it will come to the UK maybe by the end of the year, so it's important that we know about this study. The study tested resmetirom in patients who have got cirrhosis. It wasn't placebo-controlled, and there was no histological endpoints. The authors looked at non-invasive liver marker improvements, including liver stiffness and clinically significant portal hypertension, which we know is the most important aspect for patients with cirrhosis because this is usually the driver of complications and progression of liver disease. We can see from the trial data that liver stiffness improved after 1 year of treatment, and then improvement was seen even more after 2 years. Interestingly, we saw some of the patients had a decrease in their liver stiffness reading from F4 to F3. When they looked at the clinically significant portal hypertension, they divided the patients into 3 groups. So those with a baseline low risk for clinically significant portal hypertension, those with a high risk, and those who did already have clinically significant portal hypertension. You can see in the first group that a very small amount progressed. Those who had a small amount had a high risk at their baseline. Only a few of those progressed to significant portal hypertension. And those who had clinically significant portal hypertension at baseline, only a few of them then progressed. So this shows promising results for resmetirom in MARSLD. So this second half of the presentation, I will talk about treatments of PBC. Some of this isn't new information, but I think when we talk about PBC, we have to talk about the treatment options as a whole. We all know that the first-line treatment for PBC is ursodeoxycholic acid. Treatment response is then assessed after a year, and then we may consider the second-line therapy. So how do we define a response to treatment for PBC? There is a lack of agreement in the definitions of a non-response. Common themes support a reduction in ALP as the most important response to treatment. Currently, the goal isn't actually an ALP normalization, which makes it quite difficult when looking at when to escalate therapy. We often use the PBC risk score, which can help decide if treatment needs to be escalated. FibroScans have not been validated for assessing disease progression in PBC, so it's not included in the response criteria of the trials, which makes it quite difficult. It was mentioned at EASL that a liver stiffness of less than 10 predicts a good outcome in PBC patients. So these are our current options for second-line therapy. You have the PPAR agonists, so elafibranor, seladelpar, and bezafibrate, which is unlicensed, and we have obeticholic acid, which was approved in 2017. So I'll briefly talk more about each of those individually. This is quite a busy slide, but the slide summarizes the trials for each of the second-line therapies in PBC. They all achieved the primary endpoint, so they looked at an ALP of less than 1.67 times the upper limit of normal, an ALP decrease of greater than or equal to 15%, and a normal bilirubin. Elafibranor, seladelpar, and bezafibrate achieved normalization of ALP and a reduction in itch. OCA was associated with an itch. There's limited data for fibrosis. We will go into some of this in the next slides. The response trial did show that the response trial did include FibroScans, but it's not been reported yet in the literature. There was a sub-study of the POISE trial that evaluated liver histology and ductopenia using paired liver biopsies and did show an improvement in the liver fibrosis and bile duct integrity. These are the patient characteristics that were included in each of the trials, and you can see that the patient characteristics were similar across all trials. It mainly included women who were white and in their 50s, which generally represents the patient cohort in PBC. The trials excluded patients that had advanced cirrhosis or episodes of decompensation, and the newer trials included a washout period for patients who had been on fibrates. So obeticholic acid, or OCA, was NICE approved in 2017 for second-line therapy in PBC. It works by activating FXR, which is a receptor that regulates bile acid metabolism and reduces liver inflammation and fibrosis. which helps to prevent further damage in patients with PBC. It's currently not being used in America or Europe because the license has been revoked. The reason for that is because the Cobalt study, which was set up as a confirmatory trial to evaluate long-term efficacy of OCA, was stopped early as it was struggling to recruit patients because we knew the benefit. So that's why in the US and the UK they're not using it. We currently do still have a license in the UK. Elafibranor is one of the PPAR agonists. It works by reducing bile acid production and improves lipid metabolism and lowers inflammation in PBC. It was approved last year in 2024. So from the elafibranor elative trial, we could see that there was not a significant reduction in itch using the WI-NRS scale, but we did see an improvement using the PBC-40 and the 5D itch domains. More evidence this year at EASL showed that elafibranor improved fatigue versus placebo. We can see from the figures that elafibranor showed an improvement in fatigue scores from baseline to week 52 compared to the placebo, and this was more pronounced in patients who had moderate to severe fatigue at baseline. There was also a late breaker presentation on elafibranor, which showed more research of protein screening in association with the response, which is very interesting. Seladelpar is another PPAR agonist that decreases bile acid synthesis and itch and improves liver function in PBC. It's currently awaiting NICE approval, but it's available on the early access scheme. The response trials showed that there was an improvement in itch. Interestingly, you can see here that there was actually an improvement in itch in the placebo arm as well, which may have been due to patient expectations, but actually the difference in the two is significant, so there is a clear improvement in itch with seladelpar. Data from EASL this year also showed that there's an improvement in the 5D itch sleep disturbance compared to placebo. We also saw from EASL this year that there was an improvement in the GLOBE score with seladelpar over time. Now, this isn't new evidence, but I think it's important to mention that there have been some patients that have been put on triple therapy, so with ursodeoxycholic acid, OCA, and bezafibrate. We couldn't use triple therapy with our newer agents, elafibranor and seladelpar, because of their same mechanism of action as bezafibrate, so we couldn't use those. But this triple therapy has shown promising results. When you look at the OCA trial, you can see a reduction in the ALP quite quickly, and then it tends to flatten off. When you add in these other two agents, we can see a further reduction in ALP, so that could be a promising combination of therapies to try and achieve normalization of ALP in the future. Again, another quite heavy slide here, but this is just a summary of the licensing of all of these second-line drugs. So you can see here that none of these have been licensed in Child-Pugh B or C cirrhosis or in patients that have had previous decompensation event. The FDA has recently updated the OCA licensing to include patients that have decompensated cirrhosis or an episode of decompensated cirrhosis or an episode of portal hypertension as a contraindication, and that's because there have been serious liver injuries in patients with advanced cirrhosis. We can see that OCA increases itch and LDL cholesterol, and we can see that elafibranor improves itch. We may need to monitor for muscle injury, especially with statins if they're on elafibranor. We can see seladelpar also improves itch, and all of these drugs have a number of interactions that we need to consider. So this was the first data that was presented at EASL for linerixibat, which has been used for itch. This slide here shows a study design. The authors also showed that the drug works by reducing the itch score. Changes from baseline improved over time. Obviously, with the mechanism of action of this drug, some patients were experiencing diarrhea, which is to be expected. Volixibat was also presented at EASL and did show promising results. So the key takeaways from EASL are that obviously the hepatitis B guidelines are going to create a big change in our practice, and a working group needs to be established on how we manage that and make sure that we we managed it with a uniform response. There are newer treatment options for marzold, which are very exciting, and it shows that pharmacists will have a big role in this. A lot of these new drugs will be high cost and require blue tech, so it shows that we'll be having a lot more work within the MDT, putting on a lot more clinics, as well as the nurses, helping to monitor these patients. Obviously, further research is ongoing, and this talk only highlights a few of the new treatments. But I think hepatology is a very exciting place to work in, and there's lots more to come in the future. Thank you.
Lovely. Great. So if a patient qualifies for second-line therapy and does not have itch, which agent would you choose and what would influence your decision? It's a controversial question.
It's a very good question, and yeah, very good question. And I mean, we have a PBC MDT that we discuss all of our patients for. I mean, if they don't have itch, they could be considered for OCA, because we would tend to be more wary now with OCA because of the itch profile. So if somebody doesn't have any itch at baseline, you may want to consider OCA. I think you'd also need to consider lots of other things as well. So do they have any comorbidities? Are they on any other medications? There's lots of different things that need to be considered before making that decision, really.
Yeah, I think so. It's a tricky one. I think it's something we always get asked as well. But I think OCA is still a good agent. You showed sort of the evidence. I think what's quite nice as well, we've got experience in using OCA and managing side effects, which we don't sort of quite have yet for the newer agents. So, but what's great for patients is they get a choice as well. They've got three options, which is quite good. So I've got a question from Gemma. Which I'm not sure we can answer if we're going a bit off label here, but has anyone started any child PB patients on elafibranor?
Personally, at St George's, I don't believe so. We don't have much experience with elafibranor. I know Satellite Kings have local.
Yeah. I think we've sort of just stuck to what's licensed at the moment because there is a variety of medications, but I'm happy to give a fuller answer on email, Gemma. Then I've probably got time for one last question, and I promise I'll let you all go for a break. From Anthony, have you done any modelling to see how many more Hep B patients might require treatment? So Anthony looked last year, looking at patients with a viral load over 2,000, and it might mean that 50% of their cohort might need nukes. We've been talking about shared
we've
care.
not been.
Sorry, Karen. Sorry.
We haven't done any messages. Our team has grown. I think that we've newly started on treatment. We put on a lot more clinics. We do have capacity. Numbers are going to be.
Yeah, I think, sorry, I missed some of that, Hannah, because I don't know if it's my internet. There is some national modelling that's been done with numbers just generally of Hep B patients with Hep B. But you're right, Anthony, I think the numbers are going to explode, especially with the treatment thresholds lower. So I think there's a lot of certainly work in London being done about how we're going to manage that. And it's something certainly that the liver transformation project that's kind of being worked up with NHS England is looking to manage. I think there's lots of nuances with shared care and the cost of drug in the community, but those are all things that are being looked at, because I don't think it's probably right to look after all these patients in secondary, tertiary care. And I'm going to take the last question. Karen, thank you. Are you screening for Hep B and A&E? I think you are, aren't you, Hannah?
Yes, we have been doing for the last couple of years now.
Yeah.
So we've had hundreds of new Hep Bs come into clinic from the ED screening.
Yeah. And again, that data is available. I think UKHSA, if you type it in, there's public health data as well about some of the A&E testing results in about 30 or 40 odd A&Es now. So, which is great for patients, but we have to manage that capacity now. Great, thank you for all your questions. So I'm going to let you go off on a break. Sorry, I'm running a little bit late, but if you could all come back at 3:15, and then we'll start promptly then. Thank you. Hello, welcome back. So I'm really sort of excited to bring Kate Hallsworth on next, who's a very senior research physiotherapist at the Newcastle upon Tyne Hospital's NHS Foundation Trust. And Kate's going to be updating us on stigma around liver disease and the use of patient-reported experience and outcome measures. Thanks, Kate.
So thanks everyone, and thank you for kind of the invitation to come and give a very quick debrief on a couple of the sessions I attended at EASL 2025. So first of all, really what I wanted to highlight, and Diane's already touched on a couple of these sessions, but is the sessions that were incorporated as the part of the interprofessional forum. So these sessions are designed specifically to bring together multi-professional audience and are designed by the Nurse and AHP Task Force. So they really try and pick topics that are really relevant to nurses, AHPs, pharmacists, and the medics. But the reason for kind of asking a real multitude of speakers to these sessions is to really give the audience practical tips that they can take away and then try and implement in their clinical practice to initiate changes. So if you do get the chance to attend EASL next year, I'd really just recommend you just keep an eye out for the Interprofessional Forum programme, because it was a really good mix of different topics and mix of different speakers that you sometimes don't hear at other conferences. So one of the topics I've decided to focus on today was a talk provided by Professor Condili from Italy, and she was talking about how implicit bias in healthcare can lead to stigma in our patients with liver disease, and wanted to look at it from a provider's perspective. So she kind of started her talk with a quote from Hippocrates, really trying to highlight that it's far more important to know what person the disease has than what disease the person has. And it's really just trying to emphasize the importance of understanding the individual behind the illness, rather than just focusing on the specific disease or condition they may have. And she really tried to highlight the significance of recognizing each person's unique experiences, their emotions and their needs, rather than reducing them to just a label. And I think this is something that we all need to kind of recognize and try and avoid if we can. So if we're thinking about implicit bias, what is it? So this is something that affects us. It affects us all, and it's unconscious attitudes or stereotypes that can influence our behavior, our actions, and our decision making. It's generally based on lots of factors, and it's based on things like cultural conditioning, the influence the media has, learned stereotypes, and is also affected by family, peers that you grow up alongside. So this isn't something that you intentionally develop, or it's not something you intentionally kind of exhibit, but it does affect us all. So examples of this are assumptions based on age, ethnicity, language, and gender. And it really can, if we let it, it can affect our patient care. So it can affect diagnosis, it can affect the way we communicate with people, and it can affect that relationship we're trying to build, that trusting relationship we're trying to build between the healthcare provider and the patient and their families. So the clinical impact of this is that implicit bias can mean that patients receive different care based on kind of reasons unrelated to their medical needs or evidence-based practice. So it's something we really need to be conscious of and try and avoid if possible. So how does it show up in healthcare? So here are a few examples on the slide that she used where bias enters liver care. But she was just trying to really highlight that clinical decisions may be influenced by the stereotypes that we hold. So, for example, patients with alcohol-related liver disease could be viewed through a moral lens, not a health equity lens. Patients living with obesity could be blamed for their condition rather than supporting them to help manage their condition. And in some cases, we may have less engagement or spend less time with certain groups of patients. And this can lead to patients feeling dismissed and affecting their adherence or affect their health-seeking behaviours. So it might lead to higher DNA rates at some of our clinics, or patients kind of self-discharging from our wards. It can also lead to barriers to access, and this is particularly important to recognise for marginalised groups. And I know Sally will talk a lot about this in her kind of Rising Star talk after me, but we really do need to be aware of this and think of strategies to try and reduce it to help improve the care of our patients with liver disease. So she highlighted 4 different strategies for minimizing implicit bias in clinical practice. A key thing was an awareness that this existed. So recognizing our own personal biases and also the biases within the system that could impact the care of our patients with liver disease. She also recognized that education was really important, and actually we all require regular cultural competence training, but this needs to really be tailored for us as healthcare providers of patients with liver disease. Patient-centered care is really, really important, and we need to engage our patients actively and really try and respect their cultural identities. And as I say, not reduce them to a label related to their condition, because each patient is completely different. They may present with the same medical condition, but the background to that condition is likely to be completely different. And we need to understand that and respect those differences. And advocacy is really important. We need to be promoting equitable liver health policies and resources. And these should be sensitive to our diverse populations that we all see, both in outpatients and on our wards and in our communities. So some of the things she suggested to enable us to try and tackle stigma in liver disease care were things that we could do individually and those that we could think about systemically. So on an individual basis, one of the key things she brought out was using respectful language. And I've got a slide on this next, but it's thinking about the words we use, the way we say them, how we're communicating with people, because that really does not only impact the patient experience, but it does also impact clinical outcomes. We need to emphasize that the care is important over the cause of the disease and bring the care into the present rather than just focusing on what's gone before that, and express empathy and offer support to these people. And part of this is recognizing our own biases. We all do have them, but if we can start to recognize them, we can try and stop them from influencing the clinical decisions we make and our actions. Systemically, it's really important to collaborate with our communities, trying to kind of reach out into the communities to find out what do they need, how can we improve access to our services? Is it things like offering a flexible appointment system? Do we need to invest more in interpreters and translators offering multilingual services? Do we need to take our services out to the community? And again, this is something I think Sally will touch on in her talk, but these are all things we should be considering to make access easier and more equitable. And again, this cultural competency training is really important for staff working in liver services. So this is just some very kind of brief examples of biased language. But as I say, language really does matter, and small changes can transform the patient experience and outcomes. So rather than using stigmatizing terms such as obese patients, we should be referencing people living with obesity. Rather than cirrhotic patients, people living with cirrhosis. It really does make a difference both to patients and outcomes. And these are just small changes that it's going to take a while for us to change the way we use these terms, but actually, if we can start doing it and start picking up on other people using stigmatizing terms and maybe trying to change their behaviors as well, it can have an impact. And this is just to highlight the EASL policy statement that was just released just before EASL. So if you wanted more information about this, it's a really nice, quite a short piece that's got lots of information in there about stigma, but also kind of gives you some suggestions as to how you can try and tackle it, both from an individual and a kind of more of an organizational perspective. So just to build on from that, one of the sessions I attended was the Interprofessional Forum workshop on PROMs and PREMs, so patient-reported outcome measures and patient-reported experience measures. And these are both really good tools to try and enable and improve patient and family-centered care and to reduce kind of stigma within our patients with liver disease. And this was a team from both Sweden and Spain that delivered the workshop. So the workshop was quite informal. It was a roundtable kind of workshop, and it was a really nice opportunity to meet a lot of different clinicians from across the world, from lots of different professional backgrounds, and to hear their experiences of using this type of measure, both within their clinical and research practice. So to start the session, we were talking about the difference between PROMs and PREMs, and we kind of came up with the fact that PROMs provided information about patients' health outcomes, whereas PREMs provided information more about the patient's experience with healthcare services. And we talked about how we were using PROMs and PREMs and when we maybe used one over the other. And what we tended to find was we tended maybe to use PROMs more in the research and the clinical setting, and PREMs more in if we were trying to do service development work or quality improvement. So it's a bit of a split between those, and there was no right or wrong answer. That was just tended to be how people were using them, and that's what the split was. We also got into a discussion about if we were using these measures, how are we using the results? So a lot of people collected the data as part of maybe research, and it didn't really influence the practice because it was part of a research study. Some people were using the outcome measures and really nicely gave examples of how it was really encouraging patient-centered care within their clinical practice. So they were using the results of those PROMs to really target what mattered to that patient at that point in time. And that really helped to shape that clinical consultation on that day. So it might be that if one of the outcomes patients were reporting itch as being a real problem, then the focus of that consultation was more on itch that day. They still covered other things, but it helped to really kind of prioritize what mattered to the patient and where that consultation should start. So we did discuss the pros and cons of a lot of different tools. And what we found was that the more generic tools, such as the SF36 and the EQ5D, they're kind of generic quality of life tools. They were quite useful in a research setting, but actually to use clinically, they were just a bit too vague to really try and kind of inform and change and improve our clinical practice. So they did have a place, but maybe not so much kind of in our clinical work. The more liver-specific and condition-specific questionnaires were the ones that were really useful to help shape those kind of clinical consultations. So a lot of people discussed using things like the PBC-10 to really kind of drill down what they wanted to talk to patients about in that consultation. So it's about thinking of why you're using the questionnaires and picking the ones that are most appropriate and that are going to give you the information that will actually either inform your practice on that day or that will give you the answers for the research that you're conducting. When it came to assessing patient experience, there were a lot less validated measures out there. And the general consensus was that we didn't really need a liver-related patient experience measure, because often what we were trying to collect data on was kind of general experience or specific experience, but not related to their liver condition. So some people used standardized questionnaires, such as this one on the right here, this pick a patient experience questionnaire that kind of was a tick kind of box questionnaire that they could use as a standardized thing with their patients. Other places, and ours is one of those, we developed kind of service-specific surveys to really get information about services that we're trying to develop, or if we changed something in practice, we wanted really specific information about that change. So it was better to maybe make something up ourselves to get the information we needed. And then there was the option and discussion around having kind of focus groups and structured interviews. And I think for some incidences, that's really important if you need really in-depth information. But there's a lot of work that then needs to go into unpicking what that information tells you and analysing that information when you get it back. So for some circumstances, that is really useful, but for others, it creates a lot of work and generates a lot of data that might not be necessary. And then other people in kind of, especially outpatient departments, if you were just trying to get quick feedback on how people's kind of experience was on that day, use things like these smiley face boards. And I'm sure people have seen them in airport security and things like that. How was your experience today? And people could just opt to take one of the smiley faces. And that's a good way of getting information from a lot of people with a lot less kind of data analysis to do in the background. So again, there's lots of different tools out there, but it's working out what information you need, how many people you need to get that information from, and picking the appropriate tool from what's available. So kind of just to summarize and bring all that together, a quote that was used in the first presentation was that bias is human, but so is change. As healthcare professionals, our goal shouldn't be perfection, but actually it's about being aware and acting for equitable care. And I really like that, because I think we always do try and aim for perfection, but actually a lot of the time, let's do the best we can with the tools we have and be as kind and caring and inclusive as we can be. We need to commit to reflection, curiosity, and culturally competent patient-centered care. And this involves seeing the person behind the illness and behind that diagnosis. We shouldn't be assuming anything about these patients. We should be asking them open-ended questions. We should be using non-judgmental language. And that really does help to improve both clinical outcomes and patient experience. So finally, I'm just going to do a little bit of a plug for EASL membership as a member of the EASL Nurse and HP Task Force. But it's just to highlight that it is only €25 per year. And if you've got any undergraduate students, they can actually sign up for membership for free. And it gives you access to a whole host of different resources. So there are access to things like JHEP reports, but there's a whole raft of online education, podcasts, webinars that you will then gain access to. The Congress next year is in Barcelona in May, and we will, if you're an EASL member, you do get quite significantly discounted registration for nurses and AHPs. And there's a big plea, I suppose, from the EASL Nurse and AHP Task Force. Please submit your abstracts. We're not just interested in research. We really want to hear about your service developments, your quality improvement projects. These pieces of work that you're doing on the ground, on the front line, are really important. And it's really important to be able to showcase this good work that's going on. So please submit your abstracts and come along to Barcelona. And as I said at the start, the interprofessional forums are really good kind of track to follow if you want to get a really varied experience. So it just leaves me to say thank you and have any questions. Thanks, Sital.
Thanks so much, Kate. That was very thought-provoking, actually. I'm just going to have a look at the Q&A chat. So I'll take chair's prerogative on this one. I had a few questions. So I'm actually doing a research project where I'm using CLDQ and some other validated questionnaires. But what I'm finding is, because they're in English and I have translated them into different languages, but often these questionnaires are developed in the English language. And this project's in patients with hepatitis B, and certainly in London, it's such a diverse ethnic range of patients. Is there any work going on about trying to develop these questionnaires with patients with different backgrounds, languages? Do you know of any? I mean, not necessarily in the world of liver, but just generally.
Yeah, I mean, it's not my area of expertise at all. And that's why I went along to these sessions, because I was really interested. And I would imagine there probably is some work going on, but I don't know who would be leading it. But it's a really important point, because the patients we deal with are so diverse. And actually, a lot of what we write in English doesn't translate into, there isn't a translation for it. So it's really important. And if we can find anything else about that type of work, I can always post it later on through the Basel kind of networks, because it is something that we need to think about doing.
Can you use some of the PROMs or PREMs kind of, not even just for research, but just kind of relatively regularly in your services to improve just your service? And the other thing I had was, do you ever actually feed back to patients?
We've used PREMs a lot recently, because we've just set up a new MASLD kind of structured education program. And basically we wanted to, we used the kind of EASL guidelines to base the content, but we really wanted to adapt it to meet the needs of the local population. So we didn't know whether we were hitting right with the information that we were giving and giving them kind of the level of information they wanted. So we've sought feedback through just a survey that we've developed. And what we tried to do is change the content of the program based on that. So we've done things like add in appointment reminders, add in an online option. We've added in written kind of supplementary information that goes out to them in the post before they come along. So it's been really useful to allow us to improve. And in terms of kind of feedback, I think I give feedback often. I talk to patients about their physical activity levels. So if they've kind of talked to me about a baseline physical activity and then they come back in and that's changed, I will kind of talk to them about it and what have they been doing differently? How's that made them feel? What do they think about the positive benefits of that? What do they think they could do next? And I use it to try and guide the conversation and the next level of goal setting and that type of thing.
Oh, perfect. Thank you so much. Thank you. I'll move on to the next talk now because I was running a bit behind. Thank you so much, Kate. So last but definitely not least, we've got Sally Tilden, who's a hepatology clinical nurse specialist based in Bristol, and she was awarded a really prestigious award from EASL, and this was around the integral work delivering All Right My Liver service, which was around identifying liver disease in the community across Bristol, North Somerset and South Gloucestershire. And it was the EASL Rising Star Award that was presented this year. Thank you, Sally.
Thank you. I'm just going to share my screen quickly. Fab, cool. So yeah, thank you very much for the introduction, Sital. Yeah, as mentioned, my name's Sally. I'm a hepatology nurse specialist working in the Bristol Royal Infirmary in Bristol. And yeah, in December last year, I found out that I was one of 2 people to have been awarded EASL's 2025 Rising Star Award after having been nominated by my colleague Dr. Kush Abusakra, which yeah, was amazing. So part of what was involved in receiving the award was going to Amsterdam to EASL in May and giving a 15-minute presentation about myself and my job and the work that I do. Whilst I initially felt very uncomfortable with the thought of having to talk about myself for 15 minutes in front of a room of people I didn't know, I actually found the process of looking back and reflecting on my career and the work that we've done and everything we've achieved through the All Right My Liver project as something that was really affirming. So yeah, really grateful to EASL and to my colleagues for affording me this opportunity. So I'm just going to talk for the next 10-15 minutes or so, and hopefully it doesn't sound too self-indulgent. So just a little bit of background about myself to start with. So I qualified as a nurse in 2017. I actually had been to uni before this and did a degree in psychology and felt pretty certain that I wanted an office job working in HR. But luckily, after having gotten a job working in a nursing home just to start paying off some student debt, I absolutely loved that and did a complete 180 in deciding what I wanted to do with my career. I was placed on the hepatology ward in the Bristol Royal Infirmary as a bit of a random placement, but I was really thrilled because I'd heard about the reputation of the staff, the senior nurses on the ward, and I'd heard that it was a really supportive environment for newly qualified nurses. I'm sure I don't need to tell everyone on this call how stressful and chaotic and unpredictable inpatient hepatology can be, but I was really well nurtured throughout the whole of my newly qualified years. And then, yeah, quite early on in my career as a BAM5 ward nurse, I was invited to a British Liver Nurses Association study day in Plymouth. And that was a really pivotal moment in helping me realise that I wasn't just a ward nurse who was working on a hepatology ward, but I was a hepatology nurse. And I just think reflecting on that made me realise how important it is for us all to try and include staff at all levels in these sort of speciality conferences and study days so that everyone is offered the opportunity to feel committed to the speciality that they're working in. So going on a few years, the pandemic was then a little bit of a catalyst in me realising that I wanted to do something with slightly more sociable hours. And I think we're really lucky that as nurses, and especially in the NHS, there are so many opportunities for career exploration and career development. It's probably one of the few jobs where having 5 different roles over 5 years isn't necessarily a bad thing, and it's actually something that's encouraged. And yeah, I was lucky enough to have experience working in the alcohol specialist nursing team, in outpatients department, and as a hepatology practice education nurse. And then I found out about my current job role as a hepatology nurse specialist specialising in outreach in 2022. So just a little bit of background about the area that I work in. I work in Bristol, which is a city in the southwest of England. It's got a population of about 500,000, so it's a relatively small city. It's creative, historical and vibrant, so Google will tell you, but it does have a disproportionately high amount of drug and alcohol related deaths. And in 2022, our department in the Bristol Royal Infirmary were one of the first sites to successfully bid to take part in an NHS England funded pilot, the Community Liver Health Check pilot, which Di mentioned in one of the post-its in her talk. And the pilot aimed to reduce the number of deaths from liver cancer. The pilot was to be modelled on the incredible hepatitis C outreach work that has gone on for many years. We were covering an area larger than just our city. So we were covering the Bristol and Severn hepatitis C operational delivery network, which it includes some of the smaller cities and the rural areas surrounding Bristol. It overall encompasses a population of around 1.2 million. Was that moved on? There we go. So when I first joined the project, it had already been given the name All Right My Liver, which if anyone on the call is familiar with the Bristolian accent, you hopefully recognise is a pun on the common Bristolian colloquialism, All Right My Lover. That was a bit tricky having to explain that to an international audience last month, but I think it went down quite well. And the plan was that our project, All Right My Liver, would run targeted screening of individuals at risk of cirrhosis using a fibroscan. Those with a score concerning for cirrhosis were brought back for further investigation. And if they were given a diagnosis of cirrhosis, they were commenced in 6-monthly HCC surveillance via ultrasound. We wanted to develop a mobile liver screening clinic, and our ethos was to ensure that we were reaching those least likely to engage with healthcare, trying to reduce healthcare inequalities and destigmatising liver disease at the same time. Now, Bristol is a relatively wealthy city compared to other parts of the UK, but it does actually have some of the poorest neighbourhoods in England, highlighting that it's a city with a massive wealth disparity. As I mentioned, it's also got a disproportionately high amount of drug and alcohol related hospital admissions and drug and alcohol related deaths. And over half of the adults in Bristol are considered to be obese. So we knew that there was a lot of potential cirrhosis out there to find. Before getting this job, I'd never been a nurse outside of a hospital setting. So I was really lucky that in my first few months, I was taken under the wing of some of the viral hepatitis nurses who'd worked in outreach for many years, and they sort of taught me how to create clinics and build clinics in non-typical settings. So that's what we did. So this is just a non-exhaustive list of some of the kind of areas that All Right My Liver now regularly runs outreach events. I've just included some pictures to give you guys an idea of what an All Right My Liver clinic sometimes looks like. So this first picture is myself and a GP colleague setting up a clinic in a field at a Gypsy, Roma and Traveller fair in Somerset, which was a really unique experience. And we were able to screen and speak to lots of people that we may never have come across in traditional hospital settings. This next picture is from a very early All Right My Liver clinic in a community centre that was running a health promotion event targeting women from the Somalian community. You can see we had to be quite flexible with building some privacy screens. These next two pictures are just examples of when we've been able to hire either a large ambulance truck or a clinical van, and we can literally park up on the side of the road outside of a hostel or wherever and run a clinic from there. And finally, this picture is when we were lucky enough to be invited to run some liver screening at Bristol City football match, which was an amazing experience. We got to speak to lots of people and do a lot of health promotion and get a lot of people thinking about liver disease. As you can imagine, setting up clinics in non-clinical settings has come with its challenges. I've had countless parking fines, flat tyres. I've gone through a couple of different cars just with breakdowns and things. Sometimes I've driven 2.5 hours down tiny country roads to not screen anybody. Equally, sometimes we've completely misjudged our comms and had queues of over 200 people wanting to be screened in a 4-hour window. And we're always trying to make sure that when we're screening, we're balancing, trying to find those most at risk of liver disease whilst also destigmatizing. But I'm pleased to say that with all of the challenges, there's been successes as well. So to date, we've screened over 7,000 people in the area who are at risk of liver cirrhosis. 12% of these people had a liver stiffness measurement of over 8.5 kilopascals, and all of these 7,000 people benefited from some brief intervention from myself or my colleague around what their risk factors for liver cirrhosis were. Of the 7,000 people, we've actually found 6% did receive a diagnosis of liver cirrhosis and are now enrolled in 6 monthly HCC surveillance. And all of these patients benefit from our pathway navigator, Becky, who's the blonde woman in the picture, who works tirelessly and flexibly to help keep people consistently turning up to their 6 monthly ultrasounds and 6 monthly appointments. The work she does is incredible, and sometimes it's as simple as she will meet the patient at the front door of the hospital, walk with them to radiology, wait for them to have the scan, walk them out. But just little things like that have made a massive difference in consistently having engagement. We've also got countless good news stories of patients where early detection of cirrhosis have meant that they've improved their health outcomes. For example, people who have become abstinent from alcohol after many years of dependency, or people who have joined local weight loss groups and lost 30 plus kilograms in weight and reduced their metabolic risk. We've hopefully managed to do some work in getting more people talking about liver disease and reducing stigma. As I mentioned, we've got continuous engagement of patients living vulnerably, and patient testimonials of the project so far have been really positive, I'm pleased to say. There's also been plenty of opportunities for research. So I've included the name, hopefully you can see those kind of clearly, of 2 publications that I've been part of. The first one is a qualitative evaluation of the pilot after the first 18 months. And the second one is looking at a resource that we were able to develop to help patients who live in financial insecurity live well for less. I used to think that as a nurse, to have your name on a publication like this, you needed a PhD. So this is just an example of some of the amazing opportunities that this job role has provided. So towards the end of my talk, just some future aspirations. So I still feel quite new in my career as a nurse specialist, and I want to continue to improve my autonomy and my clinical decision making, hoping to undertake my non-medical prescribing course in September. I want to continue to empower nurses and allied healthcare professionals to challenge stigma and keep conversations about addictions and brief intervention on everyone's agenda. I'm sure everyone on this call is acutely aware that specialist addiction care is becoming increasingly difficult to find, and I want to empower nurses and allied healthcare professionals to be able to have these conversations with patients themselves. I want to continue to keep contributing to research, being part of a national and international hepatology community such as EASL and Basel, and most importantly, continue to advocate for hepatology patients and improve liver health inequalities that we know many, many people face. Finally, I just want to say a massive thank you to colleagues, friends, my department, and all of our collaborators. This list is non-exhaustive, but the only reason I've been able to achieve this award is because I'm part of a supportive and dynamic team who are constantly pushing my progression and my development. And I'm really grateful. And thank you to EASL and thank you to Basel and everyone on this call just for giving me the opportunity to talk about my work again.
Well, congratulations on the award and all the work that you do.
Thank you.
I'm going to bring back the rest of the speakers as well. I've got just one question in the chat so far. If you're able to share your references for your publications, please, if that's all right.
Yes, definitely. Yeah.
I mean, I just had one question about how you see this being developed across the country, and, you know, what do you think about other healthcare professionals, be it GP practices or mental health services or even community pharmacies, can do some of these things to kind of release that burden of, you know, a very sort of singular, very good nurse and team.
Yeah, I think especially when it comes to people who have got risks of liver cirrhosis because of addictions, I think if we can empower community teams to be having these conversations with patients and signposting and early intervention, there's so much benefit to be had with that. I think as well, of course, I'm sure a lot of people on the call are really familiar with what the Community Liver Health Check project is, and it is ultimately about finding liver cancer earlier. But I think what the sites who have been involved with this project for a while are starting to realise that actually a lot of what we're not recording is the benefit in finding people not with liver cancer but with liver cirrhosis and sort of advanced fibrosis earlier, and the benefit that hopefully that will have in terms of stopping sort of decompensation and late stage diagnosis and things like that. And I think just getting liver disease at the forefront of kind of other healthcare professionals' mind, I think, yeah, it's going to be incredibly beneficial, hopefully.
And do you find that the patients, have they sort of ever come back kind of wanting more information? Or the other question I had was, what's the kind of referral rate, and do they actually come to their follow-up appointments once they are referred in?
Yeah, so I think we have about, of our patients from this project who have been diagnosed with liver cirrhosis, I think we have about 86% attendance, which I think is for hepatology is pretty good. And I have to say that's pretty much solely down to the work that Becky does, which she's a BAM4 patient navigator, and I think it's absolutely worth her weight in gold. Just in, sometimes it's literally just telephoning the patient the day before and saying, remember, you've got this, and this is the bus that you need to get there. And I'm getting distracted now with talking about that. But yeah, but I think that a lot of the time when I'm sat in clinic and I'm speaking with these patients, they don't want to speak to me, they want to speak to Becky. And I think we're just really getting a sense of the value of, similarly to what Kate was talking about sort of equity of care in the last talk. Like, a lot of people don't have phones and their first language isn't English, and we send letters out and they're possibly housed unstably, and we're maybe sending it to an address that they haven't lived at for months. And it's just sort of thinking a bit flexibly and creatively, and it doesn't need AI, it doesn't need a big sort of complicated database, it just needs a person who has got the time to try and contact these patients. But we're getting as I said, we've ran some qualitative evaluation of the project, and we're getting a lot of really positive feedback from patients about that side of it.
Oh, that's so nice to hear. Did anyone else have any other questions? Previous speakers, there's some really lovely comments, by the way, Sally, in the chat. One from Tanya.
I'm just reading. Yeah. I'm going to go red.
And thanks, Karen.
I just wanted to say thank you, Sally, and it's really highlighted some excellent work that's been done, and we're really looking forward to having you as part of our Liver Nurse community and the wider Basel team. So yeah, well done.
Thank you.
We're really
Thanks, everyone.
very proud of you.
Thank you.
Great. And Kate, I had a quick last question, and then I might give everyone 5 minutes back. Are there any sort of community support things for with physios and dietitians specific to liver disease?
So I suppose we've got BAL, which is the British Association for Allied Health Professionals, and that would be our go-to one kind of nationally. And it predominantly is dietitians and physios. We have reached out to other allied health professionals. And then there's the EASL kind of nurse and AHP task force, and we come under that as well. Is that kind of the kind of thing you were looking for, or more patient facing?
Yeah, more patient facing things. So like, there's a lot of community health projects happening at the moment, but I personally haven't heard of any that are sort of dietetic focused or physio.
I'm not aware of any, and I think we're in such short supply anyway that it's really tricky to find physios and dietitians that solely focus in liver disease. So we're trying to kind of build the numbers. I know a lot of my patients are signposted to places like the British Liver Trust and our local support groups if they want more information related to diet and physical activity and exercise. But that's kind of probably all we have access to at the moment. There might be other people who've got more awareness that can stick something in the Q&A. But
yeah, thank you. And then Catherine would just like to give a plug to the Basel EDI group and ongoing work. She thinks that the last two presentations in particular resonate with that. I know that the EDI group has definitely been reinvigorated within Basel. And if you just go to the Basel website, I think there's a page with the new sort of statement and what Basel are trying to achieve from an EDI perspective. And they're also very good at sort of inviting speakers and getting ideas and pieces of good work that's happening across the country. Lovely. Well, if there's no further questions, thank you so much, everyone, for joining. it takes a lot of hard work from the organisers. I know Dianne, my colleague Ian, Kate and Sally and Hannah, thank you so much for speaking and taking your afternoon out to give us all these lovely updates from EASL, especially for those that couldn't attend this year. So hopefully we'll do this again next year, and have a good afternoon, everyone. Maybe treat yourself to a lolly or an ice cream or something. Thanks all.